this evening, and as Victoria said, we will talk about vestibular syndrome, and we're going to try to give a multidisciplinary approach from the clinical point of view, from the radiologist point of view, and see how can we mix all this knowledge. So this lecture will be mainly divided in 3 parts. So the first part, we're going to talk about, if we want to understand the vestibular syndrome, is mandatory that we know the neuroanatomy, is mandatory that we know the central and the peripheral components of the vestibular system, which is kind of the top tips of how can we interpret those clinical signs that are associated with vestibular syndrome. And then it's important, and you will see that we apply the clinical reasoning, and the clinical reasoning in neurology is mainly taking into account the signalment. We need to know the onset. We need to know how is that clinical course, if there is lateralization, if it's bilateral and symmetrical, if there is pain associated to the area. And then obviously talking about the vestibular syndrome, do we think the dysfunction is mainly associated with the peripheral? We think is mainly associated with the central component. And Fraser will talk about the imaging modalities, when is better MRI, do they complement with CT, how can we interpret those findings? And then the last part, I will go back and get the last slides. Let's discuss the diagnosis dilemmas, when still you will see there are still a lot of question marks. So talking about the vestibular system can be defined as the neurology of balance, no? And the vestibular system is a pure sensory system. What does it do? It's responsible for keeping us orientated with respect to the gravity. So obviously, if this cat would not have a beautiful and very functional vestibular system, will not be located there. So what the vestibular system does is control the movement of the eyes, the trunk and the limbs according to the movement of the head. So when we have a dysfunction of the vestibular system, we're going to have clinical signs associated with a problem with the balance, either with the trunk and the limbs, they are going to be leaning, falling, or a vestibular dysfunction, a balance dysfunction associated with the eyes. Yeah, so these are the main that we will see clinical signs associated with a dysfunction of the vestibular system. So talking about the anatomy, the vestibular system, as we said, is the balance, no? Is the system of balance. And the receptors that detect that movement of the head, those receptors are located in the inner ear. And in the inner ear, we have the vestibular system, the part of the vestibular system that has the receptors. So when we move the head, that endolympha, that liquid inside the semicircular canals activates those receptors, and that information is going to reach the central part of the vestibular system. So when we talk about the peripheral, you will see is mainly associated with the structures in the inner ear. And the inner ear is inside a bone, and that bone is the petrosal bone, which belongs to the part of the temporal bone. And that receptors they're going to make the peripheral nerve, the axon, that is going to become the vestibular nerve. And the vestibular nerve also will be joined by the cochlear nerve, which is the one in charge of hearing. And together they are two sensory systems that will form the vestibulocochlear nerve. And that is what we call about the peripheral vestibular. And when they have to reach the cranial cavity, they do it through a foramen, which is called the internal acoustic meatus. So where we have the bulla, so the bulla, we have the middle ear that we know is full of air. And then here we have a little hole where the tympanic membrane is located. And this is called the external acoustic meatus. So the one that is inside, the one that will connect and will go into the cranial cavity, that arises from the petrosal bone, is the internal acoustic meatus. And then those axons are going to reach the central nervous system. And when that information gets into the central nervous system, is going to send information to the vestibular nuclei. There are different nuclei located in the brainstem, particularly in the medulla oblongata, and you have different nuclei that are going to get that information, but also information that comes from the inner ear will go to a particular part of the cerebellum that is called the flocculonodular lobe. So the cerebellum is also involved in the vestibular system, so there is a close relation of the function of the vestibular system with the cerebellum. So this is why with cerebellar lesions, we can also have clinical signs associated with vestibular dysfunction. And as we said, when we talk about the central vestibular system that contains the part of the vestibular, the central vestibular system, we have the part in the medulla oblongata where we have your vestibular nuclei, but also this little lobe, which is called the flocculonodular lobe, that also has vestibular function. And this is what we call the central vestibular system. So when we talk about central vestibular syndrome, is because we have a lesion that is affected one of the structures of this area. If we talk about the peripheral vestibular syndrome, is because we have clinical signs associated with a dysfunction of the structures that are in the inner ear. So a pure middle ear disease will not cause you vestibular signs. To have vestibular signs, you can have middle ear, but it will be middle and inner ear. Because as we said, the vestibular system is, the peripheral one is located in the inner ear. So which are the clinical signs? And we will see now, we cannot rely on a structure, so we cannot rely just on clinical signs associated with the vestibular system. So if you just rely on vestibular signs, you will not be able to differentiate between central and peripheral. We will see that there is the vertical nystagmus, but I will not rely just on that, and we will talk about that later. So it's important to know the neuroanatomy, which other structures are very close with the inner ear. And another one that also use the internal acoustic meatus is the facial nerve. So the facial nerve exit the cranial cavity through the same foramen, and this is through the internal acoustic meatus. And importantly, the facial nerve has different functions. One of the most important function is motor, and is motor to the muscles of facial expression, and is sensory to the 2/3 of the rostral to the tongue and the inner part of the pinna, but also has parasympathetic function. And that parasympathetic function is mainly to the lacrimal glands, to the nasal glands, and some of the salivary glands. So when it exits through the internal acoustic meatus, at the level of the petrosal bone, it bifurcates. So the parasympathetic component, it will go rostrally, but the motor component, it will go through the, very close to the bulla, and it will exit through the stylomastoid foramen. So if we have a lesion at that level, once it has bifurcated, we may see vestibular signs, but also facial, mainly motor activity. However, if we have a severe lesion in the petrosal bone, we will not have just the facial. It's very likely we also have the parasympathetic damage to the facial nerve. And that parasympathetic damage, what is going to cause? It's going to cause neurogenic keratoconjunctivitis sicca, what is commonly known as the dry eye, but the neurogenic underlying cause, and also the chiromicteria, the neurogenic dry nose, and associated vestibular signs. So if we have a dog, for instance, that presents with vestibular signs, neurogenic keratoconjunctivitis sicca, and chiromicteria, and otherwise we don't have any clinical signs of a central involvement, then this is a severe lesion affecting at the level of the inner ear. Severe lesion in the meaning that is affecting the facial and is affecting also the vestibular. And then there's another innervation that goes very close to the middle ear, that is the postganglionic axon of the sympathetic innervation to the eye. So we have the little ganglion, that is the cranial cervical ganglion, and this is the one that gives the sympathetic innervation to the eye, the one that lays the pupil. So when we have a dysfunction of that sympathetic innervation to the eye, we have this myotic pupil, we have clinical signs consistent with Horner's syndrome. So that postganglionic axon goes very, very close to the middle ear, and it enters again through the tympano-occipital fissure, enter through the cranial cavity, and it exits through the orbital fissure. But talking about the anatomy of the middle ear, you can have affection of the postganglionic axon. And this is cases that we see with vestibular signs. So we know there is an inner ear neurolocalization. So is the peripheral, and also probably a component of the middle ear, because we have also affection of the postganglionic sympathetic innervation to the eye. And these are the clinical signs that are going to point you that we have potentially a peripheral vestibular system involvement, or we may just see vestibular signs without facial involvement, without sympathetic innervation to the eye, or without dysfunction of the sympathetic innervation to the eye. What happened with the central one? The central one, we have other structures, very important structures that goes at the same level. So if you remember, this is the brainstem. So this is the midbrain, this is the pons, and this is the medulla oblongata. Number 8 is located in the rostral part of the medulla oblongata, and we have all these vestibular nuclei. And there is an important function at that level, which is the ascending reticular activity system that make us having a alert and bright mental status. So they are very important for the evaluation of the for the mental status. So if we have an affection of the medulla oblongata at that level, one of the clinical signs that can be present is that they have an alteration of the mental status, as it could be obtundation, they are lethargic, the onset is a little bit quieter. So these should already bring your attention that may be a clinical signs of a central component. With a peripheral, they may be disoriented, so the mental status, they may be very like, it's like anything is spinning around you, so they may be quite disorientated, but they should not be obtunded, they should not be lethargic. And if we have a lesion that is affecting, again, the part of the cerebellum that is the flocculonodular lobe, then it can cause what is known as the paradoxical vestibular. If we have a paradoxical vestibular and it affects the cerebellum, your mental status may not be affected, because in the cerebellum, we don't have components that of the ascending reticular activity system, and therefore it should not really affect your mental status. And this is for the central vestibular system. Other important pathways that goes very close to the central vestibular system, doesn't mean that they belong to the central vestibular system, but they run very close, are the proprioceptive pathways. And the proprioceptive pathways at the level of the medulla oblongata, they run ipsilateral. So unless, with the exception of the paradoxical, if there are postural reaction deficits, they will be ipsilateral to the lesion. And then we have other cranial nerves, because again, we remember the vestibulocochlear nerve is number 8, but we can have other neurological deficits associated with other cranial nerve dysfunction. So the ones that are close to 8, so it could be 7, 6, 5, and then caudal, obviously the rest. So if we have dysfunction of those cranial nerves, we can have static Estravismus and a medial one, and that will be a dysfunction of the abducent cranial nerve. I will not rely on the facial nerve, because as you know, that can also be affected with the peripheral, because they are very anatomically, they are very close. But if you have decreased facial sensation, we know is done by the trigeminal, or there is masticatory muscle atrophy. We know that is done by the mandibular branch of the trigeminal, or caudal to the vestibulocochlear nerve. We have the glossopharyngeal, which is 9, and the vagus, which is 10, which they are involved on the gag reflex. So all this evaluation of the cranial nerve can help you to see if you have a central or peripheral. And then this is mainly a very basic anatomy, but now going about the function, we need to think a little bit like electrical activity. So the vestibular system, it has equal electrical activity, and then the areas that are involved, as we said, are the crista ampularis, all these receptors in the inner ear, the saccule, the macule, and then we have the vestibular nuclei, and then we have the flocculonodular lobe in the cerebellum. So when we move the head, we have this electrical activity, and then, sorry, another of the anatomies from the flocculonodular lobe, these axons goes, obviously, if you know, the cerebellum is attached to the brainstem by peduncle, so there are 3 big columns of bilateral, so in total of 6, so 3 big columns of white matter. And the one that is receiving information and sending information from the vestibular nuclei is the one involved with the caudal cerebral peduncle. So this is the structures. And again, electrically, we have electrical activity coming from the inner ear. It will always be positive electrical activity. And remember that when the cerebellum sends information, like efferent information, it always be inhibitory. So the cerebellum always inhibits. And then we get a balance, we don't have any disturbances. So when we talk about the vestibular syndrome, the vestibular signs, and this is always, there is no paradoxical on this, the vestibular signs, they are always towards the side of less electrical activity. So if we have a lesion either in the inner ear or in the medulla oblongata, the vestibular signs are going to be towards the side of less electrical activity. And this is why you cannot rely on the vestibular signs alone to differentiate if we're talking about a central or a peripheral, because the vestibular signs is going to be leaning, is going to have a head tilt, is going to have a pathological nystagmus, sometimes have this rolling. So they're going to be clinical signs associated with a disturbance of the balance and towards the side of less electrical activity. So in this case, we can say that the vestibular signs are always ipsilateral towards the side of the lesion, but the exception will be the paradoxical. So when we get this electrical activity in the vestibular nuclei, as we said at the beginning, the first slide, they are in charge of what? They are in charge of controlling the movement of the eyes and the trunk and the limbs. So just imagine that information, that electrical activity is going to send information to the spinal cord because it controls the movement of the trunk and the movement of the limbs. Also to the eyes because it controls the movement of the eyes, and obviously to the forebrain because we are consciously aware when we are leaning towards one side or we change our balance. So when we send that information towards the spinal cord, what is the normal information? What is the normal function that the vestibular system do? So what it does is gonna constrict your extensors and inhibit your flexors. So when we are leaning towards that side, it's gonna constrict your extensors, you inhibit your flexors, and contralaterally, you inhibit your extensors. So this is why the cat or the dog is leaning, is always gonna give contraction of the extensors and is gonna inhibit your flexors. And that's the normal function. So now you can imagine what happens when this doesn't work. So I'm gonna be falling and leaning because I'm not able to constrict my extensors towards that side. And sometimes, not always, you can see contralateral extension because you cannot inhibit the contralateral extensors muscles. And this is what explains the vestibular ataxia and the head tilt, because you lose that constriction of your extensor muscles. So the dog and the cat is going to have a head tilt, is going to have potentially a contralateral increased tone, and is going to have leaning and falling, that uncoordinated gait that is characterized by the vestibular ataxia. What happens when you have the bilateral and symmetrical is a very particular clinical sign that they have this Y excursion of the heads. It doesn't tell you if it's central, it doesn't tell you if it's peripheral, but then you need to recognize that Y extensions of the head as a clinical sign consistent with bilateral vestibular dysfunction. Again, it doesn't tell you if it's central or peripheral, just tell you if it's bilateral. And then the other information, as we said, is going to control the eyes. And to control the eyes, you remember that you have all these extraocular muscles, and the extraocular muscles are innervated by the oculomotor, the trochlear, and the abducens. And it sends bilateral information to give your vestibulo-ocular reflex. So when we move the head, you have this movement of the eyes, and you don't have to see, you don't have to be visual. You can close your eyes, move your head, and you will still feel your eyeballs moving. And that is your vestibulo-ocular reflex. So when we move the head, the eyeballs will try to follow the object, and then you have this vestibulo-ocular reflex that is known as the physiological nystagmus. And we can evaluate that holding the head and moving the head towards one side and the other, and you can see this rhythmic physiological nystagmus. So when we have a lesion, for instance, if we have a lesion towards the left, we can see, or towards the right in this case, on the right side, we can see a decreased vestibulo-ocular reflex towards the site of the lesion. In this case, towards the site of less electrical activity. So this is another clinical sign that you can see with central or with peripheral. You cannot differentiate. Other thing that we can see when we have an alteration of the communication from the vestibular to the movement of the eyes, we can see this pathological nystagmus. And pathological nystagmus can be characterized by being horizontal, vertical, or rotatory. The three of them can be seen with central. The only one that you will be only seen with central is the vertical. With peripheral, you can see horizontal and rotatory, but sometimes it's very difficult to differentiate between vertical and rotatory. And then another thing that tells you more is central if you change the position of the head and it becomes horizontal and it was vertical or rotatory. That's another clinical signs. But as I said, I will not rely on the clinical signs of pathological nystagmus, because you will see other clinical signs that may help you to differentiate if it's central or peripheral. And then when we classify the nystagmus, I don't know why you say, but they say the first phase is always away from the lesion. So in the end, what you have is an imbalance of the eyeball. So you fall towards the sides that they don't have the electrical input, and then the contralateral put it back to the center. So you have a slow phase towards the vestibular dysfunction and a fast phase that comes from the contralateral that put it back to the center. And this is kind of the dysfunction of the vestibular system that is manifested by a pathological nystagmus. And pathological nystagmus is something that can be seen on resting, so just looking at the patient, or sometimes challenging the position of those eyeballs, like lifting up the head, you can elicit, because the pathological nystagmus is probably the first thing that the body tried to compensate, because otherwise imagine everything is spinning around you. So this is the first thing that they try to compensate. So if you put it upside down, you probably can elicit again. But if you already see vestibular signs as head tilt, vestibular ataxia, there is no point to put it upside down, because you already have clinical signs consistent with a vestibular syndrome. And the only thing that you may do probably is that patient is going to become more dizzy, or even feel a nauseous stimulus, just because trying to elicit a pathological nystagmus. And remember as well that we have this congenital pendular resting nystagmus that is nothing to do with the vestibular system, and we should be able to differentiate. It is just associated with an abnormal input to the system that control the eye's movement related to the vision. And one of the theories is that there is an aberration of architecture in the visual pathway, sometimes with the axons crossing at the level of the optic chiasm. With the Siamese and the white Persian cats, they has been seen that they have more crossing to the contralateral projection. And interestingly, on the Belgian Shepherd, it has shown a completely even lack of optic chiasm, and there is not a contralateral projection, and both of them have this congenital pendular resting nystagmus. It should not get worse, and it should not have other clinical signs of vestibular dysfunction. And then Estravismus, this is another clinical sign that we can see with vestibular dysfunction. It's very important that we just not say Estravismus, because if you define Estravismus, Estravismus is just an abnormal position of the eyeball relative to the orbit. We want to know is a static Estravismus, and a static Estravismus means that you don't challenge the position of that eyeball and you see an abnormal position of the eyeball relative to the orbit. And this is not neurological, sorry, this is not vestibular. This could be associated with a retrobulbar, it could be associated with one of the extraocular muscles, it could be associated with one of the cranial nerves that innervates the extraocular muscles, but it's nothing to do with the vestibular system. The position of vestibular strabismus is the one when we challenge the position of the head, and then the eyeball cannot follow the movement of the head because of the lack of balance, and by gravity is gonna go ventral. And this is a static this is a position of vestibular strabismus. So if you look at this dog, obviously the posture shows the left-sided head tilt. And then when we evaluate the strabismus, can you see we can even elicit now the pathological nystagmus, and we see the positional or vestibular strabismus. And I don't know if you realize, but it's very important when you evaluate for strabismus is that you reposition the head. So look, I'm gonna do lifting up the head without reposition the head in a normal position. And then you are not able to see the positional vestibular because for gravity you don't see it. So it's important that you put it in a normal position and then you lift it up, because otherwise it falls like that. But because the head is also tilted, you may not be able to see it. So just remember to reposition the head and then you lift it up. So you can see now we have seen all the clinical signs associated with the vestibular dysfunction. And as you can see, don't rely on those to differentiate if it's central or peripheral, because you are going to be able to see other clinical signs that will tell you. And with the exception of the paradoxical, that obviously we don't have time to go through the paradoxical, they will always be ipsilateral to the lesion. So when we talk about the typical or the things that we need to look, no? So with peripheral, when we talk about paresis, you will not see it on peripheral. You can see it with the central. Mental status with central, they may be obtunded. With peripheral, they may be disoriented, but they can be totally alert. Cranial nerve deficit, you can have other cranial nerve deficits around the vestibular cochlear nerve, so probably from 5th to 12th. And if there is any other cranial nerve with a peripheral, it will be the facial nerve. Horner syndrome with central is possible, but is rare. Because if you remember, the first neuron, so is also going through the at the level of the brainstem, is this tectotegmental spinal tract, but is rare. And then with the peripheral, if there's affection of the middle ear, it's also possible to see Horner. And then again, the nystagmus, we know the vertical can only see with central, and horizontal and rotatory can be central or peripheral. But as we said, don't rely on just the the vestibular signs. Look about mental status, paresis, or other cranial nerves. That is what is going to help us to differentiate if it's central or peripheral. And then one important thing is that if you don't see signs of central involvement, it doesn't mean that it still cannot be a central lesion, because it may be a lesion that is just affecting the vestibular nuclei. So neurological examination, and this is a recent paper from last year, can help to identify if there is a central. But if you don't see signs of central, you cannot rule out a central involvement. However, if you see clinical signs quite obvious of a petrosal bone, like it could be, as we said before, the facial neuropathy with the parasympathetic component, and mentally they are bright, alert, and responsive, there is very unlikely. So one thing that we can say, it has a vestibular syndrome, for instance, without signs of central involvement, but you cannot 100% rule that out. So talking about the differentials, it's important, as we said before, that we use the clinical reasoning. And the clinical reasoning, we need to know the onset, we need to know the clinical course, any degree of lateralization, any signs of pain, and then obviously central versus peripheral, if we can differentiate them. And then talking about the etiological diagnosis, we can have different conditions that can affect either the peripheral vestibular syndrome or the central vestibular syndrome. And we will see now how imaging how can imaging help us to narrow the list of differential. But we cannot rely just on imaging. As we said, it's very important that we use our clinical reasoning. And the list of differentials, mainly we're talking about the peripheral vestibular syndrome. We can have otitis interna associated with media, we can have neoplegia, we can have polyps, we can have ototoxicity, we can have trauma, we can have metabolic, or we can have endocrine as the hypothyroidism, or the idiopathic. Idiopathic geriatric is probably one of the most common ones that we see with peripheral. They can present with per-acute onset, they can present quite severe at the onset of presentation. We barely will see alterations on advanced imaging, and they may take a long time to recover, but they usually go back to be ambulatory, and sometimes they can have a permanent head tilt or other neurological vestibular signs. And then when we talk about central, again, we can have any condition that can affect the central, for infectious, inflammatory, neoplegia, metronidazole toxicity, thiamine deficiency. And remember, when we talk about nutritional or metabolic, this may or toxic, is likely that we will see bilateral and symmetrical signs. Or if we have a per-acute onset, we can also be talking about an ischemic encephalopathy or trauma that can affect also at the level of the medulla oblongata if we have a traumatic brain injury. And then again, this is just to remember that we can not just on the neuroanatomy that I just explained you, there have been some lesions affecting the thalamus, mainly when we talk about the ischemic encephalopathy that has been associated with vestibular signs. Mainly when we talk about the paramedian lesion, that is the one seen on the 8. This is the transverse T2-weighted image and the dorsal at the level of the thalamus, and we can see lesions at the level of the paramedian can result in typical vestibular signs. Sometimes if we have these extensive dorsolateral lesions can also affect it, and less common when we have a ventrolateral lesion. But it's also seen that the majority of these cases had lesions that were extending to the midbrain, and then if we see affection of an area that is called the interstitial nucleus of Cajal and also the medial longitudinal fascicles, we can see association with vestibular signs. So don't be surprised if we have vestibular signs and your lesions is mainly affected at the level of the thalamus. And again, it's important that we use the clinical reason, and it's mainly because what we said, because if, for instance, this is a cat that presented with acute progressive signs of bilateral vestibular, and this cat has been diagnosed with thiamine deficiency. And this is something that if you have a cat that comes with acute progressive signs with bilateral, thiamine deficiency should be very, very high on your list. And this is a dog that also presented with peracute onset of vestibulocerebral signs. And again, it's very important that we take into account the history, because this dog was diagnosed with metronidazole toxicity. It did very well, it recovered. And they are the two cases that probably they don't need to go for MRI, and we can get the diagnosis just based on taking into account the history. And then also important to know, for instance, this is a 4-year-old male native French bulldog that presented with 2-week history of progressive vestibular syndrome. It was a chronic history of bilateral otitis media, so we suspected the mental status was bright, alert, so we suspected, and he also had, as you can see, absent palpebral reflex, so it tells us there is it had a dysfunction of the facial nerve. So we have facial, vestibular, had the head tilt towards the right, it was slightly leaning towards the right, had positional Estravismus, but then when we did the postural reactions, we can see they were normal on the left side, but then we wouldn't go on the right side, has right side head tilt and right postural reaction deficit. So is also the possibility that even if the dog is starting clinical signs consistent with a peripheral vestibular syndrome, they can progress depending on the condition. They may progress to a central. And this dog had a horrible middle inner ear disease that it was consistent with a otitis infectious that extended into the cranial cavity. So just because we localize into the peripheral vestibular syndrome, it doesn't mean that cannot extend and become a central. So this is something that, again, we should take it into account. And I'm sorry, I probably take a little bit longer than I wanted, but I'm gonna give the power to Fraser.
Thanks, Elsa. Great. Okay, so I shall share my screen.
Fraser, do you mind if I ask a question to Elsa before we move forward?
No, on you go. I'll just share my screen, and then you can...
yeah. Elsa, they're asking you in the chat if you would use the positional change of the nystagmus or the frequency of the nystagmus as a sign suggestive of central versus peripheral neurolocalization.
I wouldn't, to be honest, again, I wouldn't use that for central. I think, as we said, you should look for something else, because relying on the nystagmus, again, if it changes position and you see it very obvious that is a clinical sign that is central. However, again, with horizontal and rotatory, sometimes it's so difficult to see, even if the speed, because as we said, the body, the first thing that is going to try to compensate is the nystagmus. So any change that you put in the position of the head is going to elicit a bad nystagmus if we just try to compensate it. So I would definitely don't rely on that to central or peripheral, because I think at the moment we don't have, you never know, you may someone that develop an app and he can get the frequency and the type of the nystagmus that just taking a video and then be more objective measurements. But I think nowadays on the daily clinic, I would not rely on that.
Thank you. Thank you, Fraser.
Great. Okay, so I'll give the imaging point of view now. So I guess as a radiologist, kind of what does the radiologist want to know from the neurologist when we're imaging our vestibular patients? Well, I think it's important, first of all, to know whether the signs are genuinely vestibular. So as Elsa showed, there's some mimics of vestibular disease, and we need to be confident that it is vestibular, so we're imaging the correct area. I think it's important or critical that we know whether the signs are central or peripheral. This will obviously determine which modality is appropriate, and also will help us optimize our imaging protocols so that we can actually try and identify the pathology. I think particularly for peripheral disease, history of ear disease is important. We see lots of middle ear pathology, and the history of concurrent dermatological diseases is important there when it comes to interpreting the significance. If it's peripheral, I like to know whether there's any other neurological or cranial nerve signs. So particularly if we have concurrent facial nerves, so imaging the idiopathic neuropathies needs quite high resolution images, so we may need to alter our MRI protocol there. If it's central, I think it's important, as Elsa highlighted, that we exclude the metabolic causes, which are often diagnoses made from the history and where imaging may not show any abnormalities. And then if it's central, I think it's important to know whether we are expecting an infarct, because that may again alter which protocols we use on our MRI. So we start with peripheral vestibular system first. It's obviously a very common condition, and idiopathic disease is by far the most common. So there's a really nice paper from some of my colleagues at Liverpool recently, and they showed that idiopathic disease accounts for almost 2/3. I think it's important to recognize that even with high field MRI and optimized sequences, that there's quite a high prevalence of normal MRIs. So almost half of cases of peripheral vestibular disease will have a normal MRI. And clearly that'll be even less, will have a poor sensitivity with CT. So this is a condition whereby a large number of the cases are normal, and that's quite important when it comes to, I think, in trying to interpret images and also managing owner expectation. So what are options for imaging peripheral vestibular disease? Well, back in the day, it was essentially limited to radiographs, and we could certainly get quite nice images of the bulla. It required general anesthesia and putting the animals into these kind of contorted positions. Quite challenging in larger dogs, but we could get some nice images. And there's an example here where we can see on the radiograph that there's this thickening of the bulla wall on the right, and subtle increase in opacity compared to the contralateral side. And so the image below the CT of the same dog shows pretty much similar changes. So we certainly can see middle ear pathology with the radiographs, but it was prone to very high false negative rates, and it's not a particularly sensitive modality. So probably nowadays is kind of being superseded. It's also important when we're trying to, or certainly when we're imaging our peripheral vestibular patients, that we recognize in dogs that there's quite a large variation in terms of normal conformation for the middle ear. So we can see here that in these examples that the pug bulla is quite markedly smaller in size compared to the crossbreed dog, and with quite markedly thicker walls. So this is normal breed variation, and again, but it's something which is important to recognize so we don't kind of overdiagnose bulla wall changes in some of these patients. So the choice really comes down to MRI or CT, and to some extent this is often a pragmatic choice, what modalities are available to you. This is a nice case of Elsa's, and we can see very nicely on the CT that we have, or we can see the abnormal bulla contents perfectly well on the CT. However, what we don't see in the CT is the involvement of the origins of the vestibulocochlear nerve and the abnormal meningeal enhancement on the left. So if we look on the CT, even post-contrast, these pathologies aren't visible. Now, this dog does have otitis interna on the left, and there are subtle changes in the internal, on the walls of the internal ear on the left. However, I think in the majority of cases, or certainly in a large number of cases of otitis interna, we don't see that on CT. So CT actually, I think, whilst it's undoubtedly an excellent modality for assessing, osseous changes in the middle ear, and certainly very sensitive for seeing abnormal middle ear contents, is actually, I think, pretty poor when it comes to sensitivity for showing internal ear pathology. So essentially, the choice of MRI or CT, I think undoubtedly, if we have central localization or multifocal localization, MRI is undoubtedly going to be preferred. Now, that's not to say that we can't see some central causes of vestibular disease, so things like cerebellopontine angle meningiomas or kind of large brainstem masses we'll certainly see in a CT. However, many of the lesions we see causing vestibular signs can be quite subtle, and we see commonly inflammatory disease or vascular disease, and we'll commonly see subtle cranial nerve changes, and these aren't going to be visible on a CT. So I guess it's questionable, given that it's critical to image the inner ear and the peripheral nerves, I guess it's questionable as to how appropriate CT is for imaging some of these patients. I think if we have simple questions coming through the dermatology clinic, for example, where the question is there otitis media, then undoubtedly, if there's no neurological signs, then clearly CT is an excellent modality, very fast, very quick, and will readily give us an answer as to whether we have abnormal middle ear contents or not. So this is an example here of a case. This is a dog which had intracranial bleeding, and the quite marked cerebellar changes and brainstem changes weren't visible on the CT. And actually in this case, there's also subtle changes in the left bulla which aren't visible on CT either. So MRI is probably going to be the modality of choice both for central and peripheral. In terms of MRI protocols, we want to do a standard brain protocol, but additional sequences which are valuable would be the FLAIR for assessment of the inner ear fluids. 3D sequences are very important for assessment of vestibular disease for the peripheral cases, and there's two types here which are valuable. So the heavily T2 weighted ones, such as the balanced FFE or CIS for assessment of the inner ears, and then post-contrast T1 weighted volumetric sequence with fat saturation are kind of required really for reliable assessment of the facial and vestibular cochlear nerves. Diffusion weighted imaging very helpful, particularly when we have infarction, but also when we have some middle ear pathologies, it can be quite helpful. And again, we have some options here as to which type of diffusion weighted imaging we're going to be using. Because the structures we're looking at for vestibular disease are very small, it's quite important we have kind of really high quality images. We can see here on this transverse plane image that there's asymmetry in the inner ears. This is just an artifact due to poor positioning of the transverse plane images, but it does make it very difficult to determine whether these inner ears are normal or not. So it's quite helpful if we use the dorsal T2 weighted images as a landmark for prescribing the transverse plane images. We can use the cochlear as a landmark to make sure that the transverse plane images are absolutely perfectly positioned. So this just shows you some of the images that we can get with some of these newer 3D sequences. So this is an example of a heavily T2 weighted sequence. And we can see we get very nice high resolution images of the inner ear structures. We can reformat them into different planes, and we can also do volume rendering. And we can see we get some really nice images here of the semicircular canals. And we can pick up subtle abnormalities in the lymphatic structures of the inner ear. So occasionally we'll see malformations of the inner ear. They're not very common, but this is an example I saw recently of a dog with a congenital vestibular syndrome due to a malformation of the inner ear. And we can see this essentially missing its normal semicircular canals. So we've seen very nicely on this heavily T2 weighted volumetric sequence. So I think we have lots of as a radiologist, there's lots of dilemmas when it comes to imaging our patients with vestibular disease. And I think probably the areas which give me probably the biggest headaches are determine what's the significance of fluid in the middle ears. Is it the cause of the signs? Often the changes we see with some of these vestibular patients are quite subtle, and then it can be quite hard to know whether MRI changes are genuine. And then we always have the issues to trying to correlate the clinical findings with the neural localization, and this is really where the conversation with the neurologist is critical. So that said, many cases are straightforward, and this is a kind of fairly classic example of what we see in a classic otitis media interna. So clearly we have no trouble identifying abnormal contents of both middle ears. But I think probably the key things to note here is that, as Elsa eloquently described earlier, that middle ear pathology on its own shouldn't really cause vestibular signs, and therefore it's critical that we're assessing the inner ear structures and the cranial nerves. And so we can see here in the FLAIR sequence on the top right that we have asymmetry of the signal in the lymph in the inner ears with failure of suppression on the left side. And then on the post-contrast images, we can see this abnormal meningeal enhancement and abnormal enhancement of the inner ear itself and vestibular cochlear nerve. So in this case, it'd be really no trouble making a diagnosis that this is otitis interna and could certainly explain a left-sided peripheral vestibular syndrome. However, it's important that we recognise that we have, we see commonly on cross-sectional imaging abnormalities in the middle ear, and so there's lots of other potential causes of fluid or tissue in the middle ear, which can give us a diagnostic dilemma when we have peripheral vestibular disease as a neurolocalization. So some examples would be, effusion secondary to trigeminal nerve disease. So we can have abnormal function of the tensor veli palatini muscle affecting drainage of the middle ears. Extremely commonly in our brachycephalic dogs, we'll see primary secretory otitis media. So we can see here the fairly typical appearance of this proteinaceous fluid, which is intermediate high signal on both the T2 and the T1 weighted image. And obviously, this can be often bilateral, but will give us a diagnostic dilemma when it comes to determining, is it the cause of peripheral vestibular disease or not. It can also be quite difficult to differentiate fluid from soft tissue, and this is an example of Cholesteatoma. So this is a benign expansile mass which often causes lysis, and this is a surgical condition, so it's quite important we can recognize it, and I think it's something which we see not infrequently. So they have a very characteristic but quite subtle appearance, and in this particular case, it is involving the right inner ear. So we can see the abnormal appearance to the cochlear on the right. So this cholesteatomas have abnormal keratin deposits, and they appear characteristically. We have these curvilinear or areas of very high signal on the T1 weighted sequences. So we can see that on the bottom image. They also typically will cause a degree of thinning and a degree of lysis of the bone, but unlike a tumour, they don't really show very much enhancement, or they'll show no enhancement at all. Now, this particular dog also has pathology on the left middle ear. So this dog had proteinaceous fluid due to primary secretory otitis media. And this shows the value of diffusion-weighted imaging for non-CNS disease. So one of the kind of curious features about cholesteatoma is that they show restricted diffusion. And so we can see on the diffusion-weighted image the very high signal of the cholesteatoma in the right middle ear, whereas the proteinaceous fluid on the contralateral side, we don't see restricted diffusion. So this is one example whereby we might want to use a turbospin echo diffusion-weighted image because it's less susceptible to artifacts from in the middle ear. So this would be, again, something which we might choose to do if we have it available. So middle ear disease, often can often cause otitis interna, but occasionally we'll see otitis interna as an isolated finding. So occasionally we'll see it on its own. This is pretty uncommon, but sometimes we will see labyrinthitis, as in this cat which presented with vestibular disease, and we can see the abnormal inner ears. So again, this is the sort of pathology which we're not going to be seeing on a CT. So there are some pitfalls. Obviously, assessment of the inner ear is critical. And when it comes to assessment of peripheral vestibular disease. And so on the flare, we'll often see suppression of signal in normal animals, but I think it's quite important to recognize that this is some variation, and commonly we'll see incomplete suppression of the signal in the lymph, either due to anatomical variation, so individual variation, but more commonly due to artifacts or pitfalls due to the sequence optimization of the flare sequence. So in this particular case, we can see this dog on the right. We've got this dog had a very large infarct, and there's no evidence of middle ear disease, but we can see we've got this incomplete suppression of the lymph in the inner ears. In these cases, it's always worth checking the signal in the lateral ventricles and also in the eyes, because if we have a well-optimized flare, then usually we should see complete suppression of signal in both of these other fluid-filled structures. So it's worth checking, particularly when we have bilateral changes, to look at the lateral ventricles and the eyes, just to see the degree of suppression of signal. Probably the most common cause we see of peripheral vestibular disease is the idiopathic vestibular cochlear neuropathy, which you'll commonly see in conjunction with facial neuropathy. And in most of these cases, we'll see nothing on the standard sequences. However, if we do high resolution 3D post-contrast images with fat saturation, then well, certainly for the facial neuropathies, we have quite a high sensitivity for picking up this abnormal enhancement of the facial nerve. Recognizing the involvement of the vestibular cochlear nerve is quite challenging, and so the sensitivity for this is much less. So it's about 20 to 30% of cases with vestibular cochlear neuropathy will see abnormal enhancement. So it's such a small structure, but unless you're doing kind of high resolution post-contrast images, this is something which you're not going to see, and certainly this is something which wouldn't be visible on a CT. Oops. So this is an example of kind of some of the dilemmas. So this is another French bulldog, kind of flavor of the month at the moment, and we can see it's got abnormal contents in the left bulla. It's also got congenital malformation of its cranium leading to this distortion. We see on the flare that there doesn't appear to be good suppression of this of the lymph in both inner ears. So this dog had a left-sided disease. There's no history of right-sided disease, so this is likely artifactual, although there is good suppression of signal in the lateral ventricles. On the post-contrast images, what we can see, however, is that we can see there is this abnormal enhancement on the left in the facial and vestibular cochlear nerve, and also we see very subtle abnormal enhancement within the inner ear on the left, so showing otitis interna and involvement of the vestibular cochlear nerve. So this just kind of, I think, illustrates some of the subtleties of some of these peripheral vestibular diseases. The central disease is a lot more straightforward. You know, a lot of the pathology is obvious. Some of it can be quite subtle, so particularly with inflammatory disease and infarction. So we can see in this case on the top right, this was a dog with suspect, a cat with suspect demyelination. This lesion persisted for many months and never changed. So some of these lesions, particularly with the metabolic diseases, so thiamine deficiency, metronidazole toxicity, these are easily overlooked. So it's quite critical that we have a good knowledge of the vestibular system so we can know where to look. Just finishing off, and from an imaging point of view, I think we see a lot of thalamic infarcts, lacunar infarcts causing ischemic stroke, and some of these are really subtle. And so this is a case in point. This is a fairly typical example. This is a 10-year-old Weimaraner with a fairly classic history of acute onset vestibular signs, which rapidly improved. But this dog's got multiple infarcts. We can see in its left thalamus, right cerebellar veramis, and then the left cerebellar hemisphere. So you can see that some of these are very subtle. In this case, the diffusion was really helpful, and we can see that we have two different types of diffusion here. We have the turbospin echo, which we use for looking at the middle ears and the brainstem, but has slightly less spatial resolution. And then we have the EPI diffusion, which shows this infarct in the right cerebellar veramis as the cause of this dog's clinical signs. And it's very helpful in this particular case because it showed that the other infarcts were chronic and unrelated to the clinical picture. This also shows quite nicely some of the issues with diffusion when it comes to assessment of the cerebellar brainstem, is that with the EPI sequence, we can often get these susceptibility artifacts adjacent to the middle ear, which can cause difficulties interpreting some of these more subtle lesions. So I think it's a very challenging area and certainly a very interesting area to image. Certainly tests are imaging to the full. Some of these lesions are really subtle, and often some of these dilemmas are kind of really quite challenging to resolve. So that's usually kind of my input. Hopefully we've given the neurologist an answer. Often we have many questions which need further tests, and at this point we'll kind of go back to Elsa and we'll see what our take is in some of these conundrums.
Sorry, I'm just pulling out the presentation. It was very nice. Danny, is there any question that you want to ask in the meantime? Or?
There are no questions so far.
Okay, so I'm just going to do the last part of this lecture and trying to discuss, as Fraser said, one of these dilemmas. No, so when we talk about how how significant are those clinical findings? No, so for example, how significant or what is the significance of the fluid in the middle ears that we're seeing on advanced imagings, and are the changes on the MRI genuine? Can we associate those lesions to the clinical signs? And it's interestingly because obviously when we talk about the middle ear, as we said before, if we talk about pure middle ear effusion, they are not really being the cause of the vestibular signs, but it's important to consider that we may find an incidental finding, but that may become significant, so therefore we cannot just totally ignore it. And it's interesting why when we talk about these potential incidental findings, or how significant are those findings, is totally it takes a very important role, well, the expertise of the person, the radiology, interpreting those findings. And overall, when we saw clinical signs and advanced imaging findings where you have these boundaries, like the discipline boundaries are crossed, so it may be that you need soft tissue input, you may need the dermatology input, and you may have some neuroscience to ask if you can explain those clinical signs. And for instance, one of the examples is the primary secretory otitis media that we see often in the cavaliers, that is this sterile mucus within the middle ear, and sometimes can be associated with clinical signs, sometimes can be associated with pain, sometimes can be associated with facial neuropathies. But we know that this type of dogs, they're also going to have potentially Chiari-like malformation and some associated syringomyelia, which can also be associated with pain, with this pins and needles sensation. And then how significant are those changes in the middle ear, and can give an impact on the clinical signs? And this is still a big debate. And then obviously this is not a vestibular science, but obviously we can imagine that you have a lot of mucus in the middle ear that may affect the hearing. And this is a nice study back in 2011 by Harcombe Brown, that is they evaluated the hearing in these cavaliers with primary secretory otitis media, and although the owners didn't perceive any hearing loss, we saw on the brainstem auditory evoked response, which is a very objective measurement of the hearing, that all of them had a decrease and had a degree of conductive hearing loss. So we don't really know why this is happening in the cavities. It could be because there is a increased production, or there is a decreased drainage through the auditory tube, as we can see could happen with the trigeminal neuritis, or even a combination of those. What it has been probably reported a few times is that it doesn't seem that any bacterial involvement is a primary cause for this secretory otitis. So again, this is sometimes a dilemma. Is it significant or not? We need to put probably discuss with different disciplines, but a pure primary secretory otitis, talking about the neurological signs, it should not cause vestibular, and we should evaluate, as Fraser just discussed, more in depth that part of the inner ear. And then again, the big question mark: are those clinical signs associated with the MRI findings? Do we have clinical signs associated with the peripheral involvement? Do we have clinical signs associated with the central involvement? We need to be able to put all this information together. And again, as we said, if we have a peracute onset, lateralized, central, is improving or static for the 24 hours and now improving, that is very likely is going to be vascular. So one of your main differential is going to be an ischemic encephalopathy. So this, again, you may want to report that to the imagings, because it may change your protocol. But again, clinically, if you have something that is chronic, is progressive, is lateralized, that is not going to be a vascular, because you have at least two clinical signs, chronic and progressive, that tells you those clinical signs are not consistent with an ischemic encephalopathy. And this is why we are not just taking into account is central or peripheral. We're not just not taking into account the imaging findings. We need to take into account all the clinical reasoning. You need to take into account the signalment, as I said, the onset, the clinical progression, and any signs of lateralizations are very, very important, because as we said, if you have a metronidal cell toxicity, you can definitely get from the history. And if you have any potential clinical signs of any potential in the history that cat could have, or dog thiamine deficiency, that could be probably reflected, and it may avoid going for anesthesia, and it may avoid the expense of the MRI. And again, this is one of the papers that Fraser already discussed, but probably the most common that we see is the idiopathic geriatrica when we refer to the peripheral vestibular. And as we said, they can present very, very acute on onset. And I just wanted to finish with this lovely video, because sometimes they have also nauseas, and it's also important that with the geriatric, we just do a supportive treatment, but sometimes we can need to add some meropitan, because sometimes, as we say, they can feel very dizzy. And I thought it was just a lovely video to end up this lecture. But again, if it's geriatric, the majority of them, they will recover. However, it's going to take a few weeks. One of the theories that he thinks is that there is a problem with the crystals at the level of the inner ear. They get stuck, so they have very pre-acute onset of clinical signs, and it gets a lot of time for recovering. So at least will be 3-4 weeks until they can show obvious signs, or even going back to an ambulatory status in dogs that present with severe clinical signs. And thank you so much. It has been probably a little bit longer, but hopefully you enjoyed this lecture. And as I said, thank you so much for joining us.